All right, well, welcome everybody. This is the presentation for counseling issues in the period of time between conception and infancy. I'm Corey Floyd. I'm here with Kirsten Arnold, Savannah Powell, and we're going to be talking about counseling issues that are relevant to this age cohort, then some theories of counseling that apply to working with that cohort and with parents, some approaches and techniques and developmental domains. We'll talk a bit about some barriers to implementation, and then finally some cultural considerations for counselors who address this age cohort. When we upload the PowerPoint, there will be some options for people to watch videos that we have connected to the PowerPoint that we're not going to show as a part of this presentation. And I'm also going to upload some references for the research that is cited in this PowerPoint. So Kirsten's going to start us off by talking about counseling issues.
All right, thank you, Corey. So the counseling issues that we're going to be addressing today is grief. This is this is due to the death of an infant, unexpected death, or termination of pregnancy that can change the landscape of a family. Postpartum depression, which can affect any mother, regardless of age, race, income, culture, or education. And then finally, attachment parenting, which emphasizes forming physical and emotional infant-parent bonds through designated tools. So the first that we'll be discussing is grief. Grief is a multifaceted and highly individual process, and pregnancy loss and neonatal loss can actually complicate this due to a loss of hopes for raising that child and also ambivalence regarding the status of the parent. And this ambivalence can be societal and also within the parents themselves. So it's really different from the loss of other loved ones in that there's the loss of a future, not a past. When other loved ones pass away, there are memories, we can share pictures, but with the loss of a baby, it's really the loss of the story or the imagination of what those parents had envisioned for that child's life. And parents can feel disenfranchised, a lack of social recognition for the unborn baby as a living individual, absence of cultural norms that even address how to mourn the death of an infant. And society can minimize loss, especially in the case of miscarriage. And family and friends that think that they might be helping with phrases like move on, you can have other children, you do have other children. This can actually be more hurtful than helpful. So 1 in 10 women exhibit signs of anxiety, depression, and PTSD, along with possible feelings of shame, inadequacy, that their body failed them. And one woman described this as feeling like a walking beehive where everything stung. And it's important to be aware of complicated grief, where the symptoms are more disruptive and long lasting than normal grief. And complicated grief is more likely when the death occurs suddenly, violently, or in a traumatic way, which really covers most of infant death. And it's important to know that some technology like 3D imaging, the ultrasound today, where it shows the baby and making the baby even more real. Hospitals now allow families to hold the stillborn and spend some time with a stillborn. And of course, if parents find their baby in the case of SIDS, can all be risks of complicated grief. Men are less likely to outwardly display emotional reaction, which makes it more difficult for them to seek help or even admit that they need help. And so they tend to rely more on compensatory behaviors such as increased substance use. There can be a pressure to conform to the masculine role expectations of needing to stay strong and hide the grief, and societal attitudes that pregnancy and the loss of an infant are mainly women's experiences can add to this desire to hide their grief. along with workplace policies that don't allow for paid leave following the loss of an infant, especially in the case of miscarriages for a father, or allow paid leave in case of physical and emotional exhaustion. Couples trying to be strong for one another can really inadvertently distance from one another, as there's a breakdown in communication and misunderstood feelings. So this can occur with discordant coping, where there's a difference in the expression of grief between men and women, or incongruent grieving, where parents at different times might be have a different level or of intensity in grief. Women can feel a lack of emotional response from their male partner for many of the reasons I talked about in the last slide. And there can be a lower or loss of intimacy. And sometimes this is due to a preoccupation with the deceased baby. Women can hear their babies cry, sometimes sense the baby's presence, like the baby is still inside them, feel the baby kick, and they might even hallucinate that the baby is alive. The partner as a mirror of grief can sometimes be a complex self, because while it's can be a wonderful to have your partner grieving with you, at the same time watching their pain can actually increase yours. So great sadness can morph into anger, where there's misunderstandings can be relived over and over, which then can lead to direct or indirect blaming of the spouse for the infant's death. If there are living children, it's important not to hide sadness, because they will pick up on this cue and hide sadness as well, to protect the parents. It's important to explain that the death was no one's fault to younger children, who tend to think if something bad happened, somebody has to be at fault for it. And always be open and honest as possible, but don't use euphemisms. This is very important. Telling a younger child that the baby went to sleep can then disrupt their sleep. They don't want to go to bed. And older children and teenagers may feel they need to stay strong or take on more responsibilities. So it's really important with this cohort to make sure that they understand it's okay to feel sad. They can show emotions. And also, they do not have to take care of their parents. That's not their responsibility. And here's a couple of those videos that you can look at on your own time. And then we're going to discuss postpartum depression. Postpartum depression, here we have another video that you can look at. I highly recommend this one. The baby blues affect about 50 to 85% of mothers. And this is mood swings, anxiety, trouble sleeping. Postpartum affects about 13% of mothers, and if not treated, can last months, if not longer. And this is excessive crying, severe mood swings, and thoughts of harming themselves or the baby. So if not addressed, this can then be turned into postpartum psychosis, which affects about 1%, 0.1%, excuse me, to 0.2% of mothers. And this is severe and requires immediate treatment. Mothers may experience hallucinations, delusions, paranoia, and actually attempt to harm their baby or themselves. And I do have, just as kind of a postscript, that 4 to 50% of fathers can develop paternal postpartum depression. So it's important for counselors to know this and the symptoms, which would be anger, violent behavior, either they're overworking or they have no interest in work at all, more physical symptoms like headache or stomach ache, and thoughts of suicide as well, excuse me. So there are implications for a mother bonding with their baby if they are experiencing postpartum depression. They tend to engage in less healthy practices. They might not use the back to sleep position or use the car seat, and they don't engage in positive activities with the infant, like telling stories, playing games. They may even sing lullabies faster. It's more of a mechanical response than an actual attempt to connect to the child. Mothers might engage in less healthy feeding practices, premature or inappropriate feeding, and significant breastfeeding problems and confidence issues, which then can lead to implications for the infant's health. It can affect their weight, their sleep patterns, and a greater chance of childhood illnesses like colic, diarrhea, and overall pain. So here we have some risks on this chart of postpartum depression, traumatic birth experience, lack of support. If a mother truly wants to have a home birth and for whatever reason has to go into the hospital for a C-section, uh, this can be a risk as well. So, but whatever the cause, it's first and foremost we need to understand that the mother did nothing wrong and is not a bad mother. So attachment parenting is the last issue that I'll be addressing. Attachment parenting has its roots in attachment theory, which Corey will be addressing. The three functions of attachment parenting are to provide a sense of safety and security, regulate emotions, and offer a secure base to explore. By doing this, it gives the baby confidence in the availability and responsiveness of a caregiver. Mothers were really the focus of attachment parenting for years, but more recently, fathers, grandparents, even older siblings have been recognized as significant attachment figures. The baby B's of attachment parenting, birth bonding. This is that first 6 weeks after the baby's birth, where there's skin to skin contact and constant togetherness between the parent and the baby. Breastfeeding is viewed as essential in attachment parenting. It promotes physical touch and opportunities to respond to the baby's hunger cues. Baby wearing promotes physical closeness and trust between baby and caregiver. Bed sharing eases separation anxiety at night and also makes it easier for the mother to breastfeed at night. Believing in the baby's cries means that they understand that the baby is not trying to be manipulative, but that this is their way to communicate and those cries need to be answered. Balance and boundaries is focusing in on the baby, yourself, and your family, but also knowing when to say no and ask for help. And baby trainers in the Beware baby trainers are those individuals who would give advice like, let the baby cry it out. So attachment parenting can actually be physically and emotionally demanding, especially on the mom who's kind of on demand breastfeeding. It could interrupt her healthy sleep patterns, her return to work, even intimacy with her partner. Breastfeeding can become mechanical and insensitive, where it leads to insecure attachment, where warm, interactive bottle feeding can actually lead to secure attachment. So, really, it's more about the attunement, and fed is best. While skin to skin holding and close caring is great, it's once again, it's about the attunement. Is the caretaker stressed or calm? Are they checked out? Are they engaged? And it is important to take the baby's feelings seriously, but this can be overdone to try to meet baby's every request. So understanding that mismatches are going to happen, but it's really more important for the baby to know the caretaker is going to make it right, or caregiver will make it right. And it's really kind of that flow between attunements, mismatches, and repairs that's going to develop confidence and coping skills. And probably the most controversial tool in attachment parenting is bed sharing due to the risk of SIDS. So the American Academy of Pediatrics stresses sleeping in the same room but not the same bed. By the baby having their own bed, they can be put in the back to sleep position with tight fitting sheets and no pillows or heavy comforters. And really, it's most important for the parents to enjoy the moments of connection, whether they're using attachment parenting or not, and understanding that the baby will let them know exactly what they need. So next we have Corey, who's going to discuss some of the theories um, involved with grief, attachment theory, and postpartum depression.
Thank you, Kirsten. All right, so in this section, we're going to be talking about attachment theory as it's applied to helping newborns form their autonomy and their independence. We'll be talking about interpersonal psychotherapy as it's applied to treating postpartum depression. And then finally, the stage model of grief as it's applied to helping women after miscarriage or stillbirth. So next slide, please. Let's begin with attachment theory, which is an evolutionary theory proposed by John Bowlby, you see him pictured there. And Bowlby claimed that children must form a significant bond with at least one primary caregiver, normally a mother, if they're going to achieve normal social and emotional development. And according to Bowlby, newborns attach to caregivers as an evolved strategy, primarily for managing their distress. And they use those attachments as a secure base. You heard Kirsten use that term before, from which to explore other social opportunities and social relationships. Depending on how a caregiver responds to an infant, that attachment that develops between them can be described as secure or avoidant, anxious, or disorganized. And a fundamental prediction of attachment theory is that the attachment will essentially imprint on the infant a schema for all future relationships. And in doing so, profoundly shape that infant's personality. Next slide, please. Can we go to the next slide, please? There we go. One of the common criticisms of attachment theory is that it ignores the influences of things like gender, ethnicity, culture, and especially social class on a child's social and emotional development. A great deal of research shows that these factors account for significant variance in a child's development and in that child's eventual disposition, perhaps even more than the nature of the child's attachment to a caregiver. And attachment theory, both as it was initially proposed and even as it's still currently used, largely takes very little account of those influences. Next slide. In spite of that limitation, attachment parenting, which Kirsten described, has evolved as a philosophy to promote secure attachment between infants and their parents. This approach, as you heard described, emphasizes parental responsiveness and empathy, and also continuous forms of touch, body contact, and proximity. And the goal for attachment parenting then is to support a secure attachment in order to promote autonomy and independence in newborns as they develop. Next slide, please. One therapeutic approach for treating postpartum depression is interpersonal psychotherapy, which is an evidence-based, time-limited therapy. It was originally created to treat major depressive disorder, but since then, it has been applied to psychological difficulties within 3 key areas. Those include grief, life transitions, and interpersonal conflicts. And a key feature of this approach is its focus on current rather than past relationships and interactions. It's about what's happening in a person's life currently. And also its assumption that many psychiatric symptoms are either caused by or at least exacerbated by interpersonal challenges, and most important, deficient social support. Can we go to the next slide? It's actually really difficult to critique interpersonal psychotherapy on empirical grounds. Meta-analyses show extremely high levels of support and effectiveness for this therapy across domains. But that aside, a common critique of interpersonal psychotherapy is that its time-limited approach might not offer adequate support for clients who have chronic or relapsing mental health issues. So in those situations, practitioners realize the value of ongoing maintenance sessions that would occur after the bulk of the therapy has come to an end. Another criticism is that its systematic or formulaic approach can make the therapy less effective if a client drops out early or if a client can't pay for a full course of treatment. Next slide, please. Postpartum depression has actually become one of the most common applications of interpersonal psychotherapy in the last several years, both for treating it and also for preventing it. The focus is generally on strengthening social and emotional support within a woman's social network. And therapeutically, that goal often involves both individual and group counseling, the latter of which allows women to receive support from others who are going through similar kinds of challenges in their own lives. Next slide, please. So you heard Kirsten talk about when women lose a child, say to miscarriage or stillbirth. And in those situations, grief is nearly inevitable. Elizabeth Kubler-Ross, who you see pictured here, proposed that the process of grief is often characterized by 5 distinct stages. So for women who are grieving the loss of a baby, the denial stage involves denying that the baby has died or clinging to a false hope that that news, that diagnosis is incorrect, that somewhere along the line somebody made a mistake and the infant hasn't actually died. When they move on from that to the anger stage, women tend to look for somebody to blame for their loss. So they may feel that life is unfair. They may find it absolutely incomprehensible that something like that could happen to them. When they come to the bargaining stage, women tend to entertain the false hope that they can avoid their grief through negotiation. So sometimes they'll turn to negotiating with God to say, for instance, if you bring my baby back, I will live a more righteous life. They're offering something in exchange for God taking away their grief and returning their child. When they realize that that kind of bargaining is generally ineffective, women will tend to enter the depression stage. And during this time, they report feeling numb, feeling just empty inside, and really attempting to withdraw socially and emotionally from others in their lives. When they finally reach the acceptance stage, their thought isn't, it's okay that my baby is dead. Rather, it's, my baby is dead and I'm going to be okay. So they're accepting the loss and creating a sense of optimism that they're going to be able to move on from that. Next slide, please. The most common criticisms of Kubler-Ross's model are 2. First of all, the implication that all 5 stages are necessary for healthy grieving. And second, the implication that people experience these stages in a linear manner. After the model gained some popularity, some traction in counseling and in empirical work, Kubler-Ross actually made clear that she didn't mean to advance either implication. So neither of these thoughts was part of her model, part of her argument. Instead, she argued that some people progress through the stages in a nonlinear fashion, so they may go back and forth between these stages, and that some will skip particular stages altogether. They may skip bargaining, for instance, or they may skip anger. So she tried to make clear that her intention was simply to offer the stages as a descriptive model of what grieving can look like and what it often does look like, but not necessarily a prescriptive model of what it has to look like. Next slide, please. So for mothers who are grieving, and I suppose even for fathers who are grieving after, say, a miscarriage or a stillbirth, a counselor can explain that grief is both normal and actually functional, rather than something to be feared or something to be avoided. And that counselor, in working with this model, can describe the stages of the model and make clear that the client may not experience all of them, may not experience them in order, and that that's okay. For each stage, the counselor can help the client know what to expect and understand why that stage is functional in the grieving process, what it is actually doing for the people who are grieving in terms of helping them get through their grief, so that clients become less bewildered by their grieving and hopefully less ashamed of it. Next slide, please. So now we're going to talk about some approaches, techniques, and developmental domains that are important for this age cohort, and Savannah is going to lead us in that discussion.
Thank you, Corey. In this particular section, we're going to go through just different approaches and techniques that are going to aid in the development of those in this cohort, and also how these particular issues we've described can negatively impact the development of the individuals in the cohort. Can I have the next slide, please? So how does grief affect development? So it can affect development during conception by giving some of the babies different neurological disorders. This can be anywhere from ADHD, anxiety, and it can actually decrease the cognitive function of the newborn after they come out. So babies can feel what mothers feel inside the womb. So when a parent is experiencing grief, this can be someone inside the family dynamic, or they lose a twin in the womb or anything like that. The baby can feel all of this. And infants feel it as well through parents. So if they, like I said, in a twin aspect, if one baby is lost during birth, infants can be affected through things such as abandonment. They can feel if the parent is not there, which parents should be present. Consistency is key. So you shouldn't disrupt the baby's routines. You should keep going as day to day, because they can feel all of the emotions that a parent feels. Next slide, please. So how to go through different approaches for grief. So group therapy. This can aid in the healing process for parents. Mothers and fathers can bond over the trauma that's experienced with others. Grief counseling is a big thing. This can be one-on-one with a counselor or within a group, and it allows people to know that they're not alone. They're not the only ones going through this loss. And other family members experience this loss as well, you know, grandparents, other siblings, everything to that effect. So the approaches to deal with grief is going to aid in the developmental aspect, especially for infants. Next slide, please. So how does postpartum affect the development of a baby? So for infants, their cognitive development is decreased. Mental and motor developments are lower in those mothers that don't suffer from postpartum depression. So when babies have mothers that have postpartum depression, they're generally less attached to their parents because the mother isn't really there. They don't know, you know, what it's like to have their mom like right there all the time because the mother is separated. So it's really their emotional development that's affected. The babies have insecure attachments, like previously stated. They're negatively affected as far as attention and arousal. So they're not fully there as far as emotional aspect of their lives. Next slide, please. So how to deal with postpartum depression. I think this is very, very important because I feel like this affects the baby the most because babies look towards their mothers. Their, mothers are primary in their life, especially for those that are being breastfed. So I think helping mom with stress management. Like I said, babies feel what their mothers are feeling. So when the mom is stressed, the baby can be stressed. And the babies do feel that stress that a mother, is weighing. Mothers feel like they're maybe not doing the best. So I think individual counseling is really important as well with a client-centered technique. So it'll be making this about the mother and letting her draw her own conclusions as to maybe why she's feeling like this, or what can she do to improve being a mom and help her develop confidence. Being a new mom, I'm sure, is scary to anyone. I personally don't have children, but I'm sure the first time someone's a mom, there's no how-to manual. So this can allow a mom to know that she's doing the best that she can. And it's been shown that possibly taking antidepressants, depending on how the baby's being fed, possibly taking antidepressants can help as well. There have been studies that have found that different antidepressants have been effective in treating postpartum depression. So when mothers are being properly treated and it has been addressed early, this all promotes healthy development for the baby. Next slide, please. And then which 3 developmental domains can be affected by this? First of all, I believe physical development is affected with a baby. So in moms with postpartum depression, it can affect the development of their babies. Sometimes they forget feedings. Like it was previously mentioned that the babies don't go back to the sleep position. So with mom's not sleeping, baby's not sleeping, which means the baby is awake, they're constantly tired, they're screaming, and mom doesn't know, maybe what to do. And it's just kind of like a revolving cycle. So it's important to educate parents on positive sleep routines and to put the baby back into the sleep position. This leads into cognitive development. So a baby's cognitive ability, decreases with little sleep and little nutrition. But with healthy mindsets, mom can effectively help their children develop. And when a mom has a healthy mindset, they can sit and they can play with their baby and, teach them colors. And as they get older, and they can, interact with them in a more healthy manner rather than stressing all the time. And the next one is social emotional. I think that the group therapy will help the social aspect of parents and families dealing with the different stages of grieving. I don't think that there is, once again, a how-to manual on how to grieve either. But, as people go through the different stages of grieving, I think it is important for them to have a support system that can be found through family, counseling, group therapy. Anything like that can affect the social aspect of a family dynamic. And since babies can share the mom's emotional responses in and out of the womb, it affects their emotional well-being as well. So when, like I said, moms are stressed or angry or sad or any of the above emotions, the babies feel that. So their emotional development is either increased or decreased depending on how the mom's emotions are. So I think the key is to make sure moms are as least anxious as possible, because it does transfer to the babies. Like it said before, the feedings become less personal. The sleep positions, the babies don't go back to sleep, which means the moms don't go back to sleep. All of the above and previously stated can affect a baby negatively. But when all of these issues are treated properly and addressed properly, then it affects the baby for the positive as well. Next slide. So now we're going to discuss the different barriers and implementations, excuse me. And Kirsten is going to take over for this one as well.
Okay, thank you so much, Savannah. So there are some barriers to some implementation of treatment that we're just going to take a quick look at. So barriers to treatment for women with postpartum depression, the most common barriers are no time, the stigma. This really isn't a stigma against counseling. It's more that this is supposed to be a joyful time, and admitting that they're actually not joyful, that they're depressed, is hard to admit. So, and also childcare, and a big one was cost. If a mother doesn't have health insurance, or a father, then really mental health uh, services can be prohibitive. So does seem to be a preference for therapy over medication. This is usually within individuals who have not had any experience with antidepressants before, and so they fear safety during breastfeeding and other side effects of the medication. And another research showed that with higher levels of depression equals less likely to seek treatment, which is sad, because if there's higher levels of depression, those are the individuals most likely to need treatment. And usually this is because there's been no past experience with depression or therapy, so there's no positive regard for treatment. And also just the negative thinking associated with postpartum depression may extend to negative beliefs about treatment or individual counselors themselves. So the barriers to treatment for grief, one is complicated grief. If the individual or parents have both reached complicated grief, they've probably so isolated themselves that reaching out for help, even accepting they need help, it's going to take some time and intervention. If there's a rift in the relationship, this could uh, also affect therapy, as one partner believes they want therapy, the other one doesn't want therapy. So the need for couples therapy before or with group therapy might be necessary. And then the common barriers for grief really kind of echo the common barriers for postpartum, especially that cost. Especially without insurance, stigma about the situation, and also a time, place convenience, getting both parents at the same time in the same place, and then childcare as well. So the last thing that we're going to be looking at today is some cultural considerations for counseling. And I'm going to use postpartum to address some cultural factors. Cultural factors might influence the way postpartum symptoms are experienced and even reported. Individuals with lower education and lower socioeconomic situations this might influence their experience, their self-awareness, and even how they disclose symptoms. So some might not report symptoms that would normally trigger a medical response, such as self-harm. And so it's important for counselors to understand they might have to sensitively question the individual a bit further to find if it is postpartum depression. And for individuals in lower socioeconomic situations, there is a real fear that the child is taken away if they admit that they're depressed, that they've had thoughts of suicide or harming the infant. The fear of not only that infant being taken away, but other children as they're seen as unfit parents. African American women are less likely to use the word depression. So it's important to understand that they might use phrases like they don't feel like themselves. Also, African American women typically have physical symptoms for postpartum. So headaches and stomach aches would be what they show. Asian American women might hide symptoms to protect the family from suffering or from a sense of failing or shame. And they too, usually the symptoms show as physical. American Indian communities have an incidence of postpartum depression at 20%. This is higher than all other ethnicities. So just by comparison, it's 8% in white mothers, 10% for Black mothers. So it's very important to understand the high rate of generational depression among the American Indian community, and also their lack of trust for mental health. This is due to, in many cases, a lack of mental health facilities on places like the reservations and a lack of culturally competent counselors. Also, when working with other cultures, taking into consideration other support systems. The church is often the center of African American communities, so reaching out to the clergy as a resource, especially in grief counseling, could be extremely helpful. And many American Indians also rely on spirituality. This could be traditional techniques, traditional thoughts, and also traditional combined with Christian. So including spiritual leaders when counseling American Indians is extremely important in helping with postpartum depression or grief. And family. Many cultures seek family support before any outsiders. So reaching out to uncles, aunts, grandparents of the infant, and or the siblings could be a really valuable resource. And finally, advocacy. Childcare. Well, yes, counselors can assist parents in navigating the daycare decision. Working with a daycare regarding a payment option or payment plans for a family, and also working with a daycare to get an infant into a situation with the best advantages, but that also might be closer to the parents' work or home, which would make drop off and pickup easier. Home visits. Individuals in lower socioeconomic situations are often working two jobs, and this could be both parents working two jobs. And it could be difficult to find childcare after work and also transportation. So working with them on a home visit might also be beneficial to be in the home and actually see what the home life and structure is for the infant and for the parents. And finally, working with local physicians. This can be important in discussing with physicians about the physical symptoms of postpartum and working with them on some of the sensitive questions that they could ask to see if a patient is actually suffering from a physical ailment or if they need mental health treatment. And cultural implications when parents lose an infant. This could be, how those individuals grieve and how counselors and physicians can work within the culture to allow the parents the grieving process they need.
Thank you, Kirsten, and thank you everybody for taking a look at our presentation. You know, this period of time between conception and infancy is such a critical developmental stage. So it's really valuable that clinicians and clinicians in training, such as ourselves, are sensitive to the issues that are important during that time for infants and especially for their parents and their families. So we really appreciate your attention. As I mentioned before, I'm going to attempt to post the PowerPoint itself so that you have access to the videos that we wanted to link in the PowerPoint but not show as part of the presentation. And I will also be posting a list of references to the research that we have cited during this time. So we really, really appreciate your time and attention. Thank you so much, and best for the rest of the summer.